network. Several of you have contacted Cassie Jones since we started doing these webinars to volunteer to participate in that network. This is where we find out what flu is doing, and not just flu, but RSV and other respiratory illnesses, and it's also how we identify and track novel viruses like COVID-19. We are going to be able to start our surveillance for COVID-19 through that network. So if you're interested in helping us track that information and you see patients who present with fever and cough, if you'd like to volunteer for that network, we would really appreciate it. It's a great public health effort and that you can contribute to. And you can email cassandra.jones@tn.gov if you would like to volunteer for that. And thanks to all of you who have already contacted her to volunteer. When you want updates for the state, you can go to tn.gov/health and then click the yellow coronavirus update bar at the top of the screen, and that will take you to the Tennessee Department of Health coronavirus update page. All of our numbers are updated at 2 o'clock every day, and that's where you can find the state numbers, the mortality numbers, the nursing home list, the racial and ethnic breakdown for cases, age distribution, all of that information, how many cases per county, all of that is updated on this page every day at 7 days a week. As of yesterday, we have 8,266 cases in the state with 170 deaths. We have now all but 2 of our counties reporting cases. The death rate is right at 2% for the state, and 6.7% of our tests have been positive. We have performed a little over 123,000 tests over the last few weeks, which is 1.8% of the population of the state. And our case numbers grew by 2,004 since we spoke last week, with 29 new deaths since last Friday. The breakdown of those deaths remains the same, with 82% of those deaths being in those ages 61 and older. And we monitor the floor and ICU bed space, the ventilator status, through a system that most of the state hospitals report into. And so our floor beds are at 34% as of yesterday, our available ICU beds at 32%, and the adult ventilators at 77%. These numbers have stayed really consistent through the course of the month, hovering between the low to mid-30s for the available beds and right around 75% or so for the ventilators. So that's been very consistent. There was a study that came out on hydroxychloroquine this last week that you may or may not have seen. There was a French study that came out recently of 181 patients with COVID-19, 50% of whom had received hydroxychloroquine within 48 hours of their admission, and that showed that there was no reduction in deaths or ICU rates. 8 patients developed arrhythmia thought to be from the hydroxychloroquine. And then a New York study that just came out of 600 patients across 22 hospitals in New York with no difference in outcome from hydroxychloroquine. There are currently 105 clinical studies that are enrolling people into chloroquine, hydroxychloroquine studies, either as treatment for critically ill patients, as treatment for mildly ill patients, or as prophylaxis for differing subsets of patients. So if you're interested in that, you can look at FDA and they can tell you who's doing those tests. And then a quick update about vaccines. So last week we talked about 6 vaccines that are in the pipeline. That were the most promising of them right now. There's, I think, upwards of 100 different vaccines that are being looked at. But as of this week, CDC has said that the Moderna Therapeutics mRNA vaccine that we mentioned last week is showing some promise, and there's a possibility there may be limited release as early as this fall. That would be in limited numbers. That would probably go to those who are at most risk, i.e. frontline healthcare workers and acute care facilities, but we'll keep you updated as we hear about that. And while we're talking about vaccines, there's a lot of concern about kids that are going to be missing immunizations because of the difficulty they've had going to the doctor or concerns that they've had about going to the doctor. And this came out of the New York Times yesterday. Vaccine rates drop dangerously as parents avoid doctor's visits. It's just something that we want to make sure that everyone's thinking about, that measles is still out there. We're still going to continue to have vaccine preventable illnesses that happen, and we need to make sure that the kids are getting immunized as they need to make sure that those problems aren't popping up. National Infant Immunization Week actually starts tomorrow, April 25th, and goes through May 2nd. So it's a great time if you're in a practice where you provide immunizations or you're in maybe an obstetrical practice to be thinking about promoting infant immunization and all immunizations on your websites, on your social media pages, and being sure that you're thinking about ways to adapt to the new normal of having to be more careful about how and when and where we see patients, but also making sure that we're getting immunizations into them. Today is also World Meningitis Day, and another opportunity to give messaging around the importance of immunizations to your patients. And with that, I'm going to hand it over to Dr. Levinson, who's going to talk a little bit more about tests again.
All right, good afternoon. I'm going to talk about testing, where it's being done, what's being done, and some studies that have come out since we spoke last. So next, wanted to highlight the drive-through testing sites available this weekend. Similar to last weekend, we had these surge sites throughout the state. On this slide, you can see all the sites and all the counties and the times that they're open for Saturday, April 25th. And then on the next slide, you can see it for Sunday, April 26th. These are very well attended, at least based on what we saw last weekend. So we anticipate some equally good attendance this upcoming weekend. And so I believe we did
11,000 tests last weekend.
Quite a bit of people.
And then some counties, even through the course of this week, I know Williamson County is testing down at the Williamson County Ag Center, and they did 300 and 400 tests a day this week. So all of the county health departments can test during the day. They may have varying hours, so you can call if you need to send someone over there for a test. But any of the 89 rural counties, that excludes the 6 metros, can do testing anytime during the day. If you're in a metro area, you'll want to check that out with your metro health department.
Yeah, great. All right, and next we wanted to talk about the different ways you can get a patient tested. First, you can get a sample and then send it to a contracted private lab that you've already contracted with. Another option is to obtain the sample and send it to the state public health laboratory. Keep in mind, you do have to call ahead for approval, and we'll show you that on the next slide. Another option is there are more and more CLIA-waived kind of point-of-care tests that can be used at these sites. You don't have to send away a sample to a laboratory. Some examples include the Abbott ID Now. Cepheid has a Gene Expert instrument that can do point-of-care testing. There's also other ones like the Acula, though I think the bulk of that has been diverted by TEMA. So there are options for point-of-care testing that are considered CLIA-waived that are options for rapid tests.
And I just realized I made an error on that slide. They are not diverted by TEMA, they're diverted by FEMA.
I was wondering,
oh,
yeah.
My bad.
Yeah, a lot of these, we also saw that with the Abbott ID Now, that right after they got their approval from FDA, that they were kind of snatched up by federal folks to be able to distribute across the state. So one other option that you might want to consider is there are ways you can arrange for testing by collecting a sample and then sending it away in the mail to a lab that is perhaps out of state. We'd really recommend that you, if that's an option you want to pursue, to go to the FDA website shown here. That lists all the EUAs. You want to make sure the test has an EUA, that means it's been at least reviewed by the federal government and the FDA, and also it always helps to make sure that the laboratory performing the testing has some sort of CLIA certificate. So you want to check the lab as well as the test, and that website shown on the slide is probably the best place to start. We also want to remind you that as tests become more and more available, just because it's available doesn't make it good. These can be a significant money makers for companies, and some of these tests, especially some of the more rapid ones, the serological ones, can be relatively easy to mass produce. But what you really want to look for is those studies showing that they are sensitive, specific, they've looked for cross-reactivity, and you want to make sure just because you can get one that you're actually getting actionable results from it. So just keep that in mind, and again, the FDA website is probably the best place to start if you're looking for ones that have shown that data. Going back to the State Public Health Lab, if you'd like to send your sample there, the number is up here on the screen. It does need to be approved in advance, but we are doing testing at the State Public Health Lab, especially for high risk or high priority samples, things like healthcare workers, any clusters we see in jails, detention centers, nursing homes, long-term care facilities, that kind of thing. But we do have the ability to do testing, so if you call ahead and get approval, we're happy to set that up as well. Next, we have, just to review, we touched on this last week, but if you have uninsured patients, we can also still do testing. Essentially, you need to confirm that the patient is uninsured, you administer the test, you send the samples away, the lab does the test, and essentially the clinic can invoice the State Department of Health, and that directly goes to Valerie Oliver, and you send that to her. We pay up to $70 per test, and then the TDH will process the invoice within 15 days. So that'll go back to the clinic. So there is a mechanism for testing folks, even if they don't have insurance.
And alternatively, if they have uninsured patients, they can call the state through our line, the 615-741-7247 line, and get authorization to send a test for an uninsured patient through the State Public Health Lab, and that's also done free of charge.
Yes.
So there shouldn't be a barrier that way.
Yep, variety of options. Next, I wanted to touch on what tests are available. I mentioned the emergency use authorization that FDA is providing for these tests. These tests have been at least reviewed by the FDA and have shown some level of accuracy, and they did enough review of the performance characteristics to be granted the emergency use authorization. So as of last night, when I made these slides, there were 40 EUAs available for molecular tests. There were 4 EUAs available for serological tests, and there was one in the past week that came out. It was really an update to an existing EUA through LabCorp, but it was for the collection of specimens at home, and that's run by Pixel, which is again through LabCorp. So LabCorp previously had an EUA to do COVID-19 testing. This is just an update to a specimen type that they now accept. And I want to be clear, at-home collection is not the same as at-home testing. So in this case, the testing is still done by a LabCorp laboratory, but the specimen collection can be done at home. Essentially, you go through the Pixel website, the person would have to answer the questionnaire. That gets reviewed by a Physician Wellness Network. They're the ones who determine the eligibility. They would write that prescription for the test, and then the test would be sent to the patient. It's a self-collected nasal swab. It gives you all the shipping, everything you need, instructions to then ship off to the laboratory for testing. So while the samples are collected at home, the testing is actually still done. It's a PCR test by LabCorp. Another update, if you've heard about the Abbott IV Now, this is one of those tests that can be done at point of care. It's waived. They have recently updated their acceptable specimen types. So you could do a direct swab and put it on the machine and test generally at point of care. But what they've changed now is they no longer accept samples that are in a transport media. So you can't collect the sample, put it in a viral transport media, and then test it later. The concern was that that dilution into the media could result in perhaps essentially false negatives if the patient is kind of at that low level, low positive, right at that limit of detection. By diluting it further, you can get a false negative. And so that really changes kind of the utility of this particular test in terms of where and when you can use it, but it definitely makes it better for point-of-care testing if you have a patient in front of you that you can swab and then put it on this instrument. But if there's going to be a delay in testing or sending things somewhere, another test would probably be better. And then next I wanted to talk about swabs, because that seems to be a point of mind, at least in our world, and the lack of swabs really in the world right now. One thing that's been popping up more and more is the talk of 3D printed swabs, or places that are starting to make swabs. And I never thought I would care so much about swabs, but there's actually quite a bit of work and research that has gone into developing the swabs that we typically use day to day, these flock swabs, these synthetic fiber swabs. They're engineered, surprisingly, to be very good at collecting sample, but then immediately not absorbing it and putting it into a viral transport media or something like that that's used for testing. So the challenge with these 3D printed swabs is we really don't know how they compare to those traditional swabs. There's a lot of studies being done kind of paired right now comparing them, but at this time there's limited existing data. And so the FDA mentioned that there's really insufficient data to make any recommendations on their usage at this point. There's some concern that the rosins or the plastics used to make these swabs could inhibit PCR, or it just hasn't been evaluated yet. As you sterilize these, they can become more brittle, and there's risk of breakage, which would cause a whole different issue when you're testing someone. And then finally, we really don't know how well or how good they are at actually collecting sample compared to a traditional swab, and you have to really do those side-by-side comparisons to really know that. So those are in progress, but at this moment in time, I'm not sure they're the answer quite yet. We need more information. And then finally, I just wanted to touch on recent collaboration between FDA and the U.S. Cotton. They're developing a polyester-based Q-tip type swab that's fully synthetic to assist with COVID testing. Like I said, swabs seem to kind of be the limiting factor right now in scaling up testing for everyone. And so U.S. Cotton is, because they already have the capacity to make things like Q-tips and things like that, they're actually planning to produce these new polyester swabs in large quantities to help kind of meet the needs for the COVID response. I do want to emphasize these are still polyester swabs. These are not Q-tips or swabs made of cotton. Those are generally inhibitory to molecular tests like PCR. So you definitely don't want to use cotton swabs. But these are a synthetic one, but since they already have the scale and the mechanisms in place, it's a collaboration that should hopefully fill that gap. And then finally, next, I want to talk about a study that was recently all over the news. Is in New York. They did an antibody study of about 3,000 supermarket shoppers, shown here. And what they found is about 14% of them had detectable antibodies against COVID-19. And so one interpretation of that is it could indicate that there are much higher rates of infection than we previously realized. But we really don't know much about how to interpret these findings. Again, as we kind of touched on last week, we don't know a ton about the immune response to COVID-19 at this point. You kind of, to know the long-term immune response to it, you need time to evaluate it. And so the take-home message, while this is splashy across the news, we really don't know what all this means other than potentially a lot more people were at least exposed to the virus. What that means in terms of immunity is still to be determined. And then finally, I just wanted to touch on some slides we mentioned last week. We are finding that IgG and IgM tend to be detectable at roughly the same time. IgM is a little less specific for COVID-19. There's some more potential cross-reactivity with other human coronaviruses, which is why some tests are focusing on IgG at the moment, with IgM coming out later. We still have questions about cross-reactivity with other coronaviruses. We still know neutralizing antibodies are generally the best correlate of immunity, and it's definitely something we're looking at. But at this point in time, we really don't know a lot about the neutralizing antibody response people have after getting COVID-19. So we don't know kind of whether that duration of immunity stays for more than weeks, months, years. There is some evidence that those neutralizing antibodies can vary by age, by comorbidities, and also kind of the severity of infection. So the immune response to someone who's asymptomatically exposed to COVID may be different than someone who had really severe infection. So these are the things that we're still trying to understand better. but they're big kind of caveats when it comes to getting those serological test results and kind of being able to interpret them. As I mentioned last week, more companies are getting EUAs for serological tests. There are companies now that are offering serological testing, not just EUAs, but ones that have notified the FDA that they're doing testing. For example, the Abbott Architect is a high-throughput instrument that can do IgG testing now for COVID. Quest is also offering that kind of testing, and a lot of these bigger companies with higher throughput capabilities are either very close or already offering serological testing for COVID-19. One other thing we wanted to mention is IDSA, or the Infectious Disease Society of America, put out some commentary this week about their review of serological testing and antibodies in response to COVID-19. It's pretty good. It's also very short. It's like 2.5 pages. But it phrases things really well in a digestible manner, and it really does a good job of kind of clarifying the differences in serological test quality, how you can interpret them, the limits on interpretation, considerations for use or when not to use them, as well as kind of the outstanding research questions that we still have that are in the process of being addressed. So the link to that is shown here, and if you got an extra couple minutes, it's worth a read. And then finally, reporting results. Just to review, if you do have a positive COVID-19 result, there are 3 different ways you can let us know about it. You can fax, call, or submit an electronic report. And the contact information for those options are shown here. If you have a negative COVID-19 test result, there are 2 kind of avenues you can go. If the negative result came from one of the facilities listed below, then you don't need to do anything. We'll get those results from them. However, if it's not from one of these places, then if you look on the next slide, you'll get the contact information. Here, you can always call that in. It also applies if you did a point-of-care test. We also need to know if that result is negative. You can call the number. It's 615-741-3857. And it helps to not just know about the positives, but the negatives as well. That kind of informs our denominator, so gives us a better idea of really not only how many tests we're doing, but what the results of all those tests are throughout the state.
And I just wanted to remind you, for those of you who are in need of PPE, there is a way to request that from TEMA. I've got the link up on the slide for you, but it's https://arcg.is/1, capital L, lowercase I, capital C, capital C, capital P. That's arcg.is/1, capital L, lowercase I, capital C, capital C, capital P. And then you need the passcode 8362. There's a survey there that you can respond to, tell them the type of organization you are. Last time I looked, did not say things like general pediatrics, family practice, internal medicine. So if you are one of those, you can click other and type in what you are. It'll ask you how much PPE you have on hand and when you expect to have that exhausted. And then you can request up to a 2-week supply. That PPE will be shipped directly to your address, and you can request surgical masks, N95s, gowns, gloves, face shields. All of that can be provided to you. I've heard 3 different anecdotes now of people who ordered PPE through this site over the course of the last week and had supplies anywhere from 24 hours to 3 to 4 days later. So the turnaround time is pretty quick, and I hope that can be a good resource for you. On that note, I also want to see, for those of you who saw that last week, how many of you have ordered through that site? And it looks like 10 of the 51 of you have responded so far did order. 25 of you haven't done it yet, and then 16 folks didn't need to. And then the next question, if you did order, how quickly did you get it? So 1/3 of these people got their PPE in less than 48 hours, which is fantastic. And then 58% are still waiting. So we'll ask this question again next week just to see how that looks. Recently, I've been embedded over at TEMA, and so I sit with the folks that work on some of this stuff, and it's really good feedback for them to hear how quickly these orders are going through. So just one last, well, next to last question is just how do you like the Menti questions? Do you think they're helpful? The majority of you, I will go so far as to say the vast majority of you have said that you like them. We like them. They definitely give us a way to interact with you. I'm so glad to see that none of you are so over it at this point, at least the ones that chose to respond. I'm assuming the ones who didn't respond might be in that third category. And then always, what do you want to hear about next week? And we do look at these every week and try to come up with concise ways to talk about the things that you're asking about. So that's really helpful for you to continue to let us know what's on your mind, so that we can try to address that next week on next Friday. So we will get to your questions now. You can keep sending those in through the chat, and we'll try to get to those as we go. So first, do you think we can make any inferences regarding prevalence and infectivity from countries with higher test rates? It certainly would seem that, you know, countries like Iceland, where they've got such a large percentage of their population that's been tested, that we should be able to make those kinds of inferences. I haven't seen the data from Iceland yet. I was monkeying around trying to find testing rate graphs this morning, and it was funny because Iceland was not on the list of sort of pre-populated lines on that graph, but then I figured out how to select it, and it was really interesting what they had done. So I'll see if we can't dig a little bit into those numbers from the other countries and update you on that next week. Next question, because of undetected mild cases, doesn't the number of actual cases in the U.S. have to be much higher and the mortality rate be much lower than reported? So yes, absolutely true. We have, as I mentioned, tested 0.7% of the population of the U.S., and that's actually an overestimate because many of the tests that are being reported are duplicates on the same person. So yes, likely our mortality rate is much lower because we've got pretty good numbers on mortality, but until we have more testing to understand who's infected, it's a little bit difficult to know what that number is. Other than CDC and Johns Hopkins websites, what online sources are you consulting for reliable and up-to-date information about COVID? So you can look at our site, which is tn.gov/health, and click on the yellow bar for our updates. We also have a lot of resources at the bottom of that page for different types of populations. So you can go on there to our congregate care tab and find guidance around what to do if you work with a congregate care facility, whether that's maybe a homeless shelter or foster care group homes. There's guidance on there for nursing homes. There's guidance for schools and universities, all kinds of different resources there, plus all the provider resources that we have. FDA is a good, reliable resource. CHOP has a lot of good information there. What about other things that you know of, Dr. Levinson?
I would say, especially if you have questions related to testing, the FDA FAQ website is really helpful and updated almost daily. So if you have questions about tests out there, where you can send them, what is the difference and how to interpret these different kinds of tests, if you just Google FDA, FAQ, and diagnostic tests and COVID, you'll find it. It was also linked in a previous slide in this presentation. So if you click on that, that's where I go to for the daily changes.
Yeah, and as a non-laboratorian, I was very intimidated by the FDA EUA site initially, and now that I'm on it every day, I've gotten pretty used to it, and it's really great information to be able to go, and they have all of these attachments for each of those labs where you can look and see. For healthcare providers, you can read this background. If you're a patient, you can read this. If you're looking at maybe purchasing or using this lab, you can look at all of the specs and you know, what the throughput is and whether they've tested it against normally circulating coronaviruses. It's really, really helpful and very easy to use. You can search by lab name, which is also nice, so you don't have to scroll through the whole list. And then it's also updated chronologically for the EUAs. So the most recent test is dated and at the top of the list, which is awesome. So you can pop on there every day and see that the last date of the test as of today is April 23rd. And you can look straight across and see that it's a high CLIA laboratory that can perform that test. So if you're like me and, you know, we're in an office practice, you don't need to look any further because you're not going to be using that test. There haven't been any W tests that have been approved under EUA for a couple of weeks now, and there's still only those 3. So if you want to keep an eye on that list and look for a W to pop up, maybe there'll be another CLIA wave test soon, but as of right now, we're still waiting.
Yeah, I would also add, while we talk a lot about the EUA tests, there's also lots of other laboratories listed on that FDA website. So if you don't go the EUA route, there are other labs that have notified the FDA that they are performing tests, both molecular and serological. So most of the labs you've probably heard of are on there, and it's just a really great resource to figure out who's doing what and where.
Okay, next question. We're still recommending everyone participate in TeleMed. If possible, will TDOH make future recommendations? I don't think you'll see those recommendations specifically come down from TDOH. What will come out are recommendations from likely the insurers, from TennCare, from your medical professional societies. So I would definitely keep a pulse on what they're putting out. Certainly TeleMed is great if you can do TeleMed, and most of the insurance companies are paying for that at least through the end of May. And then they'll reevaluate that and decide if they're going to extend that or not. But there are some things that just can't be done through TeleMed, and it's never been discouraged to not do those visits. So especially well-child checks, some cardiology exams where there's not great technology. There's lots of types of exams that really need to be done in person. So what many pediatricians have done is make arrangements to have maybe only well children seen in the mornings and then sick children in the afternoons, maybe screening those families to make sure that nothing or no one in that family is ill at the time, since children we know get infected less often and have less severe disease than adults do, to not only make sure that the child that's coming in for a well visit is well, but also to make sure that the family member who's bringing them is well. And then being able to get that done. There are elements of well-child visits that can be done via TeleMed to try to shorten their exposure in the office. So you could do the anticipatory guidance parts, the developmental screenings, the behavioral and social emotional health assessments via TeleMed perhaps, and then bring the child in for height, weight, fairly quick exam, and get them their immunizations. Many of our health departments have also started doing curbside immunizations, and we have a resource for that posted as well. And I plan to get one posted for how independent providers might consider doing that. But, it is possible to have a look at the child's tennis record, note what immunizations are needed, check to make sure their insurance is still valid, pull the VIS statements, do some phone consultation with the parent to let them know what the child needs, and then have them pull up to the curb, administer the vaccines, and then document that. So it's certainly possible to do that. Some might even argue that having a child in a car seat might make giving vaccinations easier in some cases. So there are ways to do it. What's very clear is that we're going to have to be ready for when school starts this fall, and it doesn't benefit anyone to make any kind of alteration in the immunization requirements for school in the fall. We've had 12 cases of measles so far this year in the country. We don't want that popping up, nor do we want pertussis or any of the other vaccine-preventable diseases that we have making outbreaks and making what's already a difficult situation even worse. So any way that we can get kids to stay on track about immunizations is really important and may just need to take some thinking out of the box. I think we're pretty clear that this virus isn't going anywhere anytime soon. We may be in this situation for a year or two, and we all, as physicians and providers, need to find a way to get back to taking care of our patients in the best way that we can. Next question is, what percentage of the unrestricted weekend tests were positive? And I don't have that number, but we can try to get it for you, or at least figure out what percentage of tests have been positive since Saturday. The health departments have been doing unrestricted testing for at least the last week and a half. So we've pretty much dropped any of the requirements or criteria to do testing through the health departments. We can try to get that number and report it to you next week with an update, and I'll try to get it posted to the FAQ. Best practices for seeing patients safely in the office: home masks on patients, 50% caseload, so no crowds, 6 feet away from most visits, et cetera. So yes, everyone in the office should be masked. So that's everyone in your office. If they're going to be 6 feet away from a patient, they can use a homemade mask. If they're going to be within 6 feet of a patient, they need to be in a surgical mask. Remember that your mask protects the other person, and their mask protects you. So you want to have patients uniformly masked as they come into the office. They can have a homemade mask, or if you have enough masks to give them a mask, that's great, but homemade masks are better than no masks. Limiting the number of people who are in direct contact with patients. So if it is typically your way to have an MA get the height and blood pressure and then take them to the room, and then a nurse go in and talk to them, and then a physician go in, you might want to make sure that one person is rooming the patient, getting the vitals, and then the provider is coming in and really trying to limit the number of times that we're going back and forth. Keep the room doors closed whenever you can, just to try to limit anything. And really what it comes down to is when we get the call that you had a positive test in your office, the first things that we're going to ask about is who was masked, who was in proximity, who do we need to worry about, who do you need to notify, and the more safety things that you can have put up there, the easier it is, and the fewer contacts end up having to be traced. State mentioned they have some antibody tests from what company? You want to check that one?
Sure. Well, I can speak for what we're doing at the State Public Health Lab. We're in the early stages with the Abbott Architect as the instrument we'll be using. Abbott's the company. They have just started shipping out IgG tests, and so we received them this week. And before we offer any tests at the laboratory, we always do validations or verification studies to make sure the tests do and behave the way they're supposed to, with varying levels of controls and panels. And so that's what we're in the stages of doing right now. We're hoping by sometime next week to have it up and ready. But that's what we're doing at the State Lab. The Abbott Architect is a high throughput instrument, so it means we can do a lot of tests at once and continuously versus a lot of these, single standalone lateral flow assays that it's one patient, one sample on one cartridge that you do one at a time. So we like these higher throughput instruments, and we think that'll really help with being able to do more serological tests for COVID throughout the state.
Great. Okay, next question. If you say requirements have dropped, how is it that physicians cannot get people tested at a nursing home that have fever, cough, and shortness of breath? What are you doing to educate nursing home facilities? So any institution can put in whatever kind of testing requirements and policies they want to. So a hospital may have requirements that maybe only children who have chronic lung condition or chronic heart condition can be tested, or a nursing home may have certain criteria. What we're doing as public health is testing anybody who feels like they need a test. We are working very closely with nursing homes in particular because of the outbreaks that have happened in nursing homes, and trying to assist them when they do have someone who's symptomatic in getting supplies. All of those nursing homes should also have relationships with laboratories. In a lot of cases, they all have medical directors, and so they should be able to send tests out to their own contracted laboratory as well. But we do continue to have dialogue with those nursing homes and to assist them in making sure that they're using good infection prevention, and that they're responding appropriately anytime they have someone who's symptomatic or who gets identified as a case. Next question, with well-child checks, should the standard precautions now with COVID-19 include gloves with staff that room patients, may even lift or touch areas where the child is but are not giving vaccinations or performing labs? You know, I think the glove requirement is a little bit squishy. So if you have someone who's not going to be in direct contact with a patient, physical contact with a patient, but maybe touching surfaces, at the very least, they need to make sure that they're washing their hands. Sometimes when you have people who aren't in direct patient contact but are wearing gloves, they have this false sense of security that they don't need to worry about their hand hygiene, or they end up going from place to place because they have gloves on, not thinking about how they might be moving infectious particles from one surface to another. So if someone's not having direct contact with patients, but they're in the room or in the facility where those patients are, they need to be washing their hands frequently for 20 seconds with soap and water, or using frequent hand sanitizer, and then making sure that those surfaces get wiped down frequently after every patient for the exam tables and the counters, making sure doorknobs and light switches are frequently sanitized to make sure that people are staying safe. Difference or best practice versus oropharyngeal or nasopharyngeal swab, patients have gotten different results from different test types. Want to answer that one?
Sure, I can take it. So right now the CDC is still recommending nasopharyngeal or NP as the preferred specimen type to be collected with an NP swab. But with swab shortages being what they are, there are other acceptable specimen types. It is pretty dependent on the test and the laboratory doing the test, so I'd always recommend, if you have questions, to reach out to whatever lab you're working with to clarify. But OP or oropharyngeal is also an acceptable specimen type most of the time. So if you are concerned about doing an NP on a patient, or if you only have OP swabs and you don't want to shove it up a child's nose, we totally understand. And OP is the better way to go in your clinical judgment. That's perfectly acceptable. To kind of get at the latter part of that, patients have gotten different results from different test types. I want to remind folks that, you know, the optimal specimen type really is kind of dependent on where the person is in their infection. So we recommend NP and OP, kind of upper respiratory specimen types, because we found those tend to be the most sensitive, and it's where the virus starts out, but throughout infection, it goes lower into lower respiratory samples. So if someone initially tests positive with one of those respiratory samples, but you have a high clinical suspicion, you can always consider retesting, and you might want to consider an alternative specimen type. So there's a lot of factors that go into it, but one reason you may get different results from different types could be because they may be at a different point in their infection, and so a different specimen type is probably the better place to find the virus if it's there. And I can take the next question, which is the Abbott ID Now molecular test acceptable for preoperatively clearance for endotracheal procedures? I believe it's acceptable at point of care. I know some places throughout the state are considering using this for pre-op clearance, and also looking at screening people in healthcare environments. I don't know the specifics. Do you know of any certain places that are already using it?
I have heard anecdotally. I haven't seen anything in writing that different hospitals across the state and across the country are using preoperative testing. of different types. Some of them are doing an antibody test, and if the antibody test is positive, then they do a molecular test to see if they can actually detect active infection or not. I think everyone's sort of taken a stab in the dark at how best to make themselves feel good about that. And the ENTs and the anesthesiologists are probably the highest risk medical providers because of the nature of the aerosolizing procedures that they do. So it's totally understandable that they want to try to rule out infection as best they can. I think it's one of those cases where a positive is helpful and a negative is not. So I think it's difficult to be reassured.
I think
in that situation.
These days, it's really, for asymptomatic people, guidance for testing is really challenging to figure out what to do and how to interpret it, understand these folks wanting to reduce the risk as best as possible, but we're all figuring it out as we go.
Next question, is there a place online where the state publishes the transmission rate of each county in Tennessee? I'm not sure what we mean exactly by transmission rate. So we don't have population statistics and what % of the population has been tested by county, but there is the number of tests that have been done, the number of positives that have been identified, and the number of deaths. And that is at the tn.gov/health site, and then click on the yellow COVID-19 updates bar at the top, and that information is updated every day at 2 o'clock. What percentage? Okay, so we've got a couple more questions about the results of the mass testing this weekend, and what do we know about the percentage of positives that came out of that? And we don't know, but I will try to get you some idea of those numbers next week.
And just to add a question I saw for next week, but I'll answer it now. To clarify, for these drive-up sites, the testing that's being done is molecular. It's diagnostic testing. We're not using these serological tests for that. So we're calling them testing sites, but really they're specimen collection sites. That's where people are getting swabbed, the samples getting collected, and they're being sent to labs in the state that are doing molecular testing looking for the virus itself.
Someone's asking, can you direct me to resources for reopening daycares other than CDC? And I would direct you to the Department of Human Services, who licenses those daycares, or to the Department of Education, who also licenses many of the daycares in the state, and they may have some resources there about guidelines for reopening. And that puts us at the end of our time. So we hope this was helpful. Please be sure to put in those comments for what you'd like to hear about next time. We'll try to get as many of your questions answered in the Q&A that we post. And we hope you'll come back next Friday at noon, and we'll talk some more. And in the meantime, stay safe. Thanks to Dr. Kara Levinson for helping us out again this week.